We are extremely pleased and proud to welcome back two of Morehouse's sons, who are also giants and trailblazers in the field of health disparities. And those of us who are here in the Atlanta University Center are so pleased to follow in the tradition of these gentlemen and many others who work hard to make sure that health disparities are no longer in existence. So we still have a lot of work to do. So we hope that today you all have communicated with one another and potentially developed some future collaborations. Immediately following this talk, we will have a reception in the main atrium. So we hope that you all could join us for that. So I don't want to waste a lot of time because I think it's going to be a very exciting and stimulating discussion. And I wanted to thank everyone for being here, and also thank Peter Thomas for moderating this session. So without further ado, welcome to all of you, and I want to introduce you to one of my favorite students, who is also a future trailblazer, Mr. Darius Quarles.
Greetings, faculty, students, and welcome to Morehouse, to all of our guests out there. It is my pleasure this afternoon to introduce you to our moderator, our esteemed moderator this evening. His resume is vast and his accomplishments are many, but I will not mention any of those to you because I posit that the most important thing is his commitment to eliminating health disparities that makes him such a great asset to our community. So without further ado, I want to welcome, and I ask that you join me in welcoming our esteemed moderator today, Dr. Peter E. Thomas.
Thank you very much. I appreciate your appreciation of me. We are here to have a conversation. Can I be heard? I'm kind of tall. Make sure. Is that audible by everyone in the back? Okay, good. I want to make sure that we have time to hear all of that we can hear from these great trailblazers that we have joining us today. I know that you have their bios already in your book, so I'm not going to spend a lot of time restating how great they are. Certainly, that it's very clear. We have Dr. Bill Jenkins with us. Not only has Bill dedicated many years to health disparities, but he served as an expert on minority issues in disease transmission as the chief of the Research and Evaluation Statistics section of the STD division at the Centers for Disease Control and the National Center for HIV and STD and TB Prevention, as well as he managed the participant health program, which assured the medical services for the survivors of the Tuskegee study of untreated syphilis in Negro males. In addition, we have, of course, Dr. Satcher with us. Dr. Satcher, as you know, was the 16th Surgeon General of the United States. He also served as director of the Centers for Disease Control and Prevention and director of the Satcher Leadership Institute, which was established in 2006, is where he now is housed. So with that said, thank you, gentlemen, very much for taking the time. Of course, I will not leave out the fact that you are Morehouse men, which, you know, those of us who are more affiliated with other HBCUs don't recognize as quickly, but I'm happy to be here, a part of this procedure for the day. So dealing with the issue of health disparities, I'll just ask a question, and as you gentlemen, you and Mike can just answer them at your leisure as we have time. And I guess the format is we will like to be able to take a few questions, so we'll have a few questions early, and then as you have questions, jot them down so that we can get them to the gentlemen, and as many as possible in the time we have. Researchers like W. Du Bois and many others identified some of the social determinants of health that disproportionately impacted populations of color over 100 years ago. Despite the vast advances that these populations have made in the last 100 years, some of these populations and some of these problems, as you know, persist. So we want to know, how do we address this? How far along are we as researchers who are focused on this community in understanding, or at least in identifying, the major driving or causal factors that lead us to some of these disparities? Please give us your thoughts on that.
Well, first, I just want to say I'm glad to be here. again. Back at CDC, one of the great series of conversations that I enjoyed was the Don and Bill show, Don Hopkins and Bill Fagey. And I think this is our fourth, so we are, now it's the David and Bill show. So, you know, so I appreciate the opportunity of being here. I think about the work of W.B. Du Bois and Booker T. Washington as being actually the providing the foundation for the work that we're doing in health disparities today. And in fact, perhaps they actually did it in a way that was more instructive because they tended to be so succinct and to the point. And what I'd like to do is just, you know, mention that that W.B. Du Bois worked in Dean Sage, just a few feet from here, and did some extraordinary work delineating those social determinants of health. And Booker T. Washington, under his program, which was then called the Tuskegee Experiment, and of course, the miseducation of the Negro means that most black people don't know anything about the Tuskegee Experiment. They think the Tuskegee study of untreated syphilis in the Negro male is the Tuskegee Experiment. But if you want to know how to work in communities, look at the Negro Health Movement, because it lays out how to get this kind of work done. So we really just need to follow the instructions of those who've gone before. I have a slide that would indicate what has happened over the last 100 years in terms of some of these factors if people want to see that. But before that, maybe David might want to comment.
Well, thank you. I'm delighted to be here at Morehouse College and certainly to be here with Bill Jenkins at the Public Health Institute. In 1900, I guess about the time that W.B. Du Bois wrote his famous book, the life expectancy in the country was 47. For whites, it was 49. For blacks, it was 34. So about 15 years separated the two groups in terms of life expectancy. And as you know, over the years, life expectancy has improved dramatically. I guess it's about 78 in the country today. And some interesting things have happened, of course. Black women now have a life expectancy of about 77. White women about 80. Black women have made more progress in closing that particular gap. Black men are still down around 72. So we've had gaps, and we have gaps. We have made some progress in closing those gaps, but disparities are very real, and they are deadly. Back in 2005, at the Morehouse School of Medicine, we published a paper in the Journal of Health Affairs, and it was entitled, "What If We Were Equal in Terms of Health?" And basically, after looking at mortality ratios over a period of 40 years, I guess it was, we were able to determine that if in the year 2000 we had eliminated the disparities in health, there would have been 83,500 fewer deaths among African Americans that year. And that's just based on the mortality ratios that we were able to identify. And as I said, in terms of black men, there had not been a lot of progress in the ratios. Some progress for black women relative to white women. So the struggle continues. A lot's going on now, but I'm sure we can deal with that a little later.
Did you want to show some of the data, just infant mortality, to show make the point, or?
I'd be glad to. Is it? Can I control it here?
Yeah, and just quickly, because one of the things that people don't realize is, next slide. Infant mortality has gone down dramatically for both blacks and whites over the last 100 years. But next slide. but what most people don't realize is the health disparities, the rate ratio between blacks and whites have not changed for 100 years. It was 2 in 1915, it was 2 in 1950, it was 2 in 2000, and today it's still right about 2. So there's progress, and then there's relative progress, and that relative disparity has remained the same for the last 100 years. And the reason for that is that, in my opinion, is that we tend to look at the wrong factors. We look at factors that are easy to measure. There was a old man who used to come to the Centers for Disease Control and tell this joke about 2 Englishmen. One was drunk and he was looking for his key on the pavement, and another man comes up and asks him, what happened? And he said, I lost my keys. And the guy said, well, where did you lose it? And the drunk man said, well, I lost it back there in the dark, but the light is better up here. And unfortunately, that's what epidemiologists tend to do. That guy, that old man, that crazy old man was Dr. Langmuir, who actually started EIS. And I'm afraid that we're still kind of doing that, and maybe we can get into those factors that I think are important a little later. But clearly, what is necessary is to have a new generation of people who will ask different questions that, instead of asking the same questions we've been asking for the last 100 years.
Amen. Okay, well, let's get into that. Then talking about what we're not measuring, or how do we measure. Certainly, I want to tap into the issue of racism, and that's a complicated health disparity issue. But let's start with a little more of the basics. As you're saying, Bill, currently, we face many public health challenges addressing infectious diseases, epidemics like HIV and many sexually transmitted diseases, for example, which are diagnosed among blacks and Latino persons at many times higher rates, at rates many times higher than among whites. I suppose that's not news to anyone. I hope not. Yet there is clear evidence that the individual risk behaviors that lead to HIV and STD transmission among these populations are not different, and in some cases less common among the African American Latinos than among whites. So, given that these individual risk factors cannot explain the large differences that we see in transmission rates, and that is more likely the social and sexual networks, the community viral load, and the social environment that explains the infection rate differences among those who are exposed and at risk, what, gentlemen, do you think are the next steps, or any steps, that should be taken by, for example, an epidemiologist, these crackerjack epidemic intelligence service officers who out saving the world? But what can be done at the very, individual level of an investigator to more effectively identify undiagnosed infection, for example, and to more systematically prevent sexual transmission among persons at risk? And I'm saying this given the idea that we have a technology now that can diagnose people pretty rapidly with HIV or other STIs and get them to care. So ignoring the technology side.
Well, actually, I have an old slide from a program that I was able to start with money given to me by our friend next to me, called Syphilis in the South. And I think I have some data on that as well. This is those disparities. A lot of people don't realize that, for example, heart disease disparities did not exist prior to 1950. That it's only been increasing since 1950. And the same thing for diabetes and a couple few others. But next slide. Where is this? Next slide. It's somewhere in there. Let's go forward. Yeah. Right. And it was to look at syphilis. One of the reasons that I wanted to look at syphilis, because it was easy to diagnose, it was easy to treat, and so what we had to do was just figure out ways to get the rate down. And the rate at the time that we started thinking about this was 67 per 100,000 among African Americans and something like 5 per 100,000 among European Americans. And what we did was to identify 26 counties and then provided funds to community organizations to develop ways of reducing syphilis rates in those 26 counties. And we got the rate down within 3 years by 50%, and it continued to go down. Of course, like the history of syphilis in this country is, once you get the rate of syphilis to go down, people take the money back, and it goes back up again. But clearly, you know, one example was to let communities figure out what's the best way to intervene into epidemics like syphilis.
Well, let me just, I guess, say a couple of things. It's interesting, of course, to look at that issue globally. And no question about it, we have made some dramatic progress in terms of infectious diseases globally. Because that's one thing about vaccines and immunizations. It is possible to really intervene more effectively. And if you look at 3 areas, polio, measles, especially, we have seen dramatic declines. Not as much in malaria, but we have seen a decline in death rates from all 3 of those. TB and AIDS, because of co-infections, have been feeding each other, so we have not gotten a handle on that yet, though most people seem to think that the HIV/AIDS epidemic has at least plateaued globally. Nobody's ready to declare any kind of victory. But I think the bottom line is that unless we deal with the social determinants of health, we are not going to be successful in dealing with these problems. Now, I served on the WHO Commission from 2005 to 2009, looking at that very issue. It's interesting. J.W. Lee, who was Director General of WHO at the time, had been around a long time. I worked with him when I was Director of the CDC on the polio eradication program. He headed the rollback TB program and the malaria program. So the assumption was that when J.W. Lee became Director General of WHO, that major focus was going to be on those infectious diseases. So I was really surprised one day when he called me and said that, you know, I want you to serve on this commission. I know about the goal of eliminating disparities in health in the United States. And he says, I would like to have a global health equity goal for the next generation. And really want to look at the role of social determinants of health. So with that, we put together a group of 24 people, and for a little over 3 years, we traveled throughout the world looking at how social issues, income, education, violence, mental health, impacted health outcomes. And I think you know the bottom line of that effort was we concluded that the conditions in which people are born, in which they grow and learn and work and age, are far more important to health outcome than health care and that health intervention. Not that those are not important, because they actually interact. Right now, for example, just to give the polio example again, last year we didn't have a single case of polio in India, which has been a leader in polio. And we had only 640-something cases in the whole world. But the 3 countries where we had polio, the issues were political and religious. In Afghanistan, of course, because of the war, there were areas where you just can't get to children with the polio vaccine. In parts of Nigeria, there were religious objections to immunization, and also the feeling that it was a plot on the part of the West to decrease fertility. So I think what we're dealing with now in terms of polio eradication is not the technology in terms of vaccine. It is the social, political, cultural issues that relate to getting the vaccines to people. That's one example, but I think overall, when you look at deaths among children especially, and they've come down dramatically in the last 10 years, the issues have been lack of access to clean water, poor nutrition, and those are the issues that we've got to do a better job of targeting. In this country, if we're going to deal with obesity and diabetes, got to deal with access to fresh fruits and vegetables in communities where there may be no grocery stores. Got to deal with the fact that a lot of people don't have access to any place where it's safe to be physically active. So we are to the point now where unless we make a real commitment to targeting the social determinants of health, we're not going to make a lot more progress, I don't think, in this effort. Now, I'm really happy that now that even NIH is funding research dealing with the social determinants of health. And I understand that 70% of the grants that they awarded last year for social determinants were R01s. And social determinants of health, that's amazing. I didn't think I'd live to see the day when NIH would be funding research in social determinants of health, but it means that we're all admitting that if we're going to be successful, if we're going to make progress, we've got to target the social determinants of health.
Thank you. So what I hear you saying then, both Dr. Satcher and Dr. Jenkins, Bill, you're talking about empowering the community, about letting the community have a part in directing what it is it needs to do to address its health or its health disparity.
Right.
And Dr. Satcher, you're saying that within that context, then what we need to be doing is looking at these social conditions and helping the community understand and direct how we help them with their social conditions.
Well, but also learning from them. We, at our institute, our philosophy is that everybody teaches and everybody learns. And we have a community health leadership program development, but the fact of the matter is that we learn a lot from those people who come from the community in terms of what we've been doing wrong in terms of trying to get health care and health interventions into communities. I think there's been a gap there, and we've got to figure out how to close that gap.
Right, and that's what we look to you two for, to be our guide, because I guess it still comes down to, at the rubber hitting the road, we're training and young minds are learning necessarily, epidemiology and sociology and the important, medicine elements that allow them to be technically skilled, but sounds like we also need them to be understanding the social determinants and the social epi, if you will, that allows us to interpret more than just individual risk factors. I guess the question I have as a follow-up is, one, is racism anywhere involved in this challenge of what we need to address or what we should be addressing? Certainly, as a social determinant, that's an issue. And secondly, what are the steps after you do assessments and you understand the disparities of the social conditions that move us in a direction to make changes that increase people's survival and quality of life?
Well, if you go back to that model that I have up there, this is where my work has led me. This right here. I think, in my opinion, in looking at the data, this is what I think is going on. And I think that a little over 30% of health disparities, that is black-white, is due to socioeconomic status. A little less than 30% is due to culture, but we don't know what that means because most African Americans are trained to believe that they're a racial group, that they are defined by their skin color. And trying to have African Americans think about themselves as a cultural group and to understand the implications of that for health disparities has been very difficult. Because if you've told somebody time and time and time again that the issue is race, and it makes them afraid to even say the word racism. If you listen to any radio or TV, most people in this country are afraid to even say that word. They say race. They will not say racism, which is the true ideologic factor. And for example, if we were to start looking at racism as the ideologic factor, we would be studying different populations. We might not even be studying African Americans initially. We might be studying some other groups, like Confederates, or segregationists, or they're now called social conservatives, but it's the same people with the same thoughts over the last 250 years. It hasn't changed very much. And so who are these people and why do they think the way they do? And how can we help them to be a little nicer? Those are things that I think that are important. Racism, I think, is also is a factor that's a little less than 30%. But we still need to study racism because there's still internalized racism. You know, I was just reading this book with this just coming out next month, where the introduction talks about black people saying the white man's ice is colder. This is a cultural phenomenon within the community that needs to be understood. When Dick Gregory stood outside of the CDC building on Clifton Road, and I was managing the first $3 million for minority health HIV prevention for CDC, I looked out the window and my reaction was, well, nobody would believe HIV was a conspiracy to commit genocide against black people. Nobody would be that stupid. Trust me, there were a whole lot of people who believed it, even though it made no biological sense, even though it means that they didn't have any understanding of the history of black people in this country, who are, when we first brought here, an economic resource for this country, and we continue to be an economic resource for this country. For example, African Americans pay 80% of the cognac market in this country. Who else drinks cognac? You know, you need African Americans in this country. That's just the reality of the situation. You know, nobody kills, you know, their property. The people who function in the best interest of this country. It's just crazy. So the question is, why did people believe it if all logic said they shouldn't? And I think we need to try to understand how these cultural factors work. And just one more example. I think most young people, if they go to a class on health or whatever, they will come away and they will tell you that the reasons that there are health disparities is the lack of access to health care and genetics and a lack of education, all of which is probably not true to a large degree. But if we had students, instead of looking at access to health care, they looked at acceptability of health care, then it would explain why, for example, African Americans in Atlanta will pass 3 major hospital centers to get back to the Grady's. You know, here in central Atlanta, we were able to, or the city was able to con black people into moving out of public housing project and put them outside the city, away from the city. So now they have to travel in to go to the Grady's, as they call it. Well, why would they pass all these fancy hospitals to get back to the Grady's? It is because they're accepted at the Grady's. And yet there's hardly anybody studying this. You know, we continue to study access to health care, and it is important, but nobody looks at acceptability of health care. Nobody looks at these cultural factors among African Americans because, unfortunately, African Americans are programmed to believe that they're a racial group rather than a cultural group. It's a tremendous tragedy, and even most young people today buy into it without even thinking.
Thank you. Dr. Satcher?
I'm learning a lot here today. No, I agree. I think the only thing I would say is I think access to health care is, when you really look at it, is a social condition that we have to deal with too. And I agree, acceptability is a component of that. The way we look at access, it includes acceptability, because if people don't find the health care acceptable, then it's going to be very hard for them to go there until the pain is unbearable or the problem is life-threatening. And you'd be surprised if we see people in the emergency room at 3 o'clock in the morning. Mrs. Jones has swollen legs, really severely swollen. So you ask Mrs. Jones, how long have your legs been swollen? Well, she said, oh, I don't know, about 6 months. And then you say, well, why are you just now coming in? And so there's still a lot of people who only seek health care when the pain is unbearable or the problem is life-threatening. So it's a very serious problem in terms of access to health care. But health care is a social condition, and to the extent that people don't have access, then it really makes it very difficult in terms of that component of dealing with health disparities. I think probably the most successful program that's been funded by the government since we started this effort back around 2000, and a lot of programs have been funded. Every institution within AU Center has received significant funding from the National Center for Minority Health and Health Disparities, now the National Institute for Minority Health and Health Disparities. No question about it. Almost 3,000 young people, primarily minorities, have received loan repayment programs just because they were interested in doing research relative to disparities in health. So I think those things have been very important. I believe the most successful program that's been funded is the so-called REACH program, Racial and Ethnic Approaches to Community Health. And I believe that's been most successful because they deal with a lot of the things that Bill was talking about. We basically decided that the money should be put in the hands of the community. And then the community could negotiate with the academic health centers, the county health departments, to the extent that they needed them to work with them. If you were dealing, for example, with diabetes, and you're concerned about the fact that among African Americans, there's so much need for amputations in people with diabetes that most people are not controlled and not heading toward control. So what we do, we put the money in the hands of people in the community, and we saw some dramatic changes in dealing with problems like that. But I think it was because they were dealing with it from the perspective of the total picture, not just the biology, which they didn't consider themselves experts in, but they had some feeling for why people didn't keep their appointments and why people didn't seek treatment until it was too late. So the REACH program, now funded by both CDC and NIH, but it's had a cut in funding, I think is the closest thing to dealing with all of those issues.
That's excellent. Thank you. You know, it sounds to me again that you're both talking about integration of you know, an integrated approach in dealing with our health disparities.
Yes.
Bill, what you've presented here is certainly a complex but comprehensive model. If you think about, for example, incarceration and the role that it plays in our health disparities, seems to me like it could fit a little bit in each one of these blocks, whether it's the fact that poor people are more likely to be imprisoned, that blacks are you know, speaking of not wanting to kill the goose, you know, the prison industrial complex certainly wouldn't do as well without the black participants that it has, that it's housing. Cultural norms of communities that, you know, kind of have the expectation about going to prison among young black men, and that's part of their rite of passage. All of those then in turn seems what you could talk about just within incarceration, how the health disparities exist among people who are more incarcerated and how each of these components contributes to them. But, you know, in that it's so complicated, and we are still working in a, you know, bricks and mortar world, how do we get there from here? You know, I kind of I'm going back to this again because I want these, you know, our young minds to be able to walk out with, you know, marching orders in some ways about, you know, what are my next steps? And of course, education is always first, but, you know, different levels of education are needed, and you don't need to be a PhD, MD, no offense, Dr. Satcher.
No offense taken.
To be able to make a contribution. And so, given the fact that there's complicated pieces of this, I guess the question I want to ask is your thoughts on how do we, one, get institutions to consider health disparities and a very tangible level of addressing them? And back to the epidemiologists, what are the steps that we as researchers can be taking, you know, in addition to measuring it, and, you know, not just EPIs, but program people as well, because at some point you have to make some changes. And right now, working in HIV, for example, we're still, our surveillance is still very much about how many partners did you have, how many sex acts did you have, you know, did you use a condom or not? While those are important, they are pretty far away from the social conditions that we're talking about. How do we get places like CDC to start capturing data, to start planning interventions, to start moving into addressing the health disparities?
It's interesting because the CDC has changed. In fact, they are now, I think, under the leadership of Kevin Fenton, really beginning to target what we call sexual health. And sexual health includes things like, why is it that some people come back over and over again with the same sexually transmitted disease. And they've been educated, they know how it's spread, and yet we're just now beginning to ask questions like, you know, what happened in your childhood? And what we find is that a large percentage of these young people have been abused. And young people, especially young women who've been abused, but also young men, are like 10 times more likely to become infected with HIV as others. So, you know, the CDC is now beginning to really focus on what is it in the society, in the community, in the home that makes some people much more susceptible to becoming infected with HIV virus or any other sexually transmitted disease, that make some young women feel like they cannot negotiate safe sex, that they're not powerful to negotiate safe sex. And so we're just now beginning to really look at that, but I have to say that the reason the CDC is doing this in great part is because of some of our fellows who, one of our young, I guess, sexual health scholars went to the CDC, and during the time that she was there, she took the Surgeon General's report on sexual health and wrote a green paper. And out of that, the CDC decided to change, and they hired her, by the way. So she now works for the CDC. So they are changing, and that's what I think we have to do. We have to keep changing. I want to say one word about incarceration, because I think that's a very important point that you made. You know, we know that, for example, the risk of HIV in prisons is, what, about 8 to 10 times greater than in society. So what happens when people go to prison and they come back into the community? That means the community is at greater risk than they were. So when our young men, especially young men, go to prison, it's like we're all being imprisoned, because when they come back, it changes the community in terms of violence, in terms of drugs, but also in terms of the risk for the spread of HIV and TB, by the way.
Thanks. So it seems like one intervention could be in itself just as a community and as individuals addressing the issue of incarceration, because not only would you address the issues of people who are being incarcerated, but also the community where the people who are incarcerated come from and come back to. That's one way to address, for example, in a very tangible way, the health disparities that might exist just around the issue and the effect of being of incarceration rates.
Yeah, and we have one of our former fellows is stayed with us and is heading a reincarceration program to really look at the whole family and how the whole family is impacted by incarceration and how that impacts the whole community. Brian McGregor, I guess, is working on that issue. But there's so much to do. It's such a complex issue. We hope that we can continue to do research in this area and to find out how we can not just deal with the people who are being incarcerated. We need to find a way to better deal with our young people who end up in prison before they end up there. But we also need a community strategy for protecting these same individuals, because when they come out, a lot of times they can't get jobs. Nobody's there trying to help them to become rehabilitated. And so they find themselves right back in prison, but they can do a lot of harm in the meantime.
Thank you.
Well, you know, one of the, well, I guess I chaired, but one of the first conferences that we had on these issues was in 1991. And the title was Health Disparities Is It Due to Race or Racism? And the CDC senior staff freaked about the racism word, which you would have expected, I guess, in 1991. But they didn't back out, and we funded it. What we thought about then was we needed to look in those categories that everybody looks at, you know, NIH, CDC, and heart disease and cancer and diabetes and so on. Because, again, that's the way we train young people to think. Young people, for the most part, are trained to answer questions. But the really important thing in education is to train young people to ask questions. A little clerk in Switzerland at the turn of the last century asked questions about gravity and changed the way we think about syphilis. Of physics. You know, Einstein changed the way we thought about it simply because he asked a different question than everybody else was asking in physics. What we need are young people who are capable of asking a question rather than coming to a lecture or a class and sitting and just and listening and memorizing and then regurgitating back. Because if that's what we're doing, we're not moving anything forward. So it really needs to start with people who are in college now or at training now before they get like me and my age and are able to think outside the box. That's what is so, so important. One of the people who have thought about things in a way that I find intriguing is Leonard Syme, probably the most successful epidemiologist in America in terms of just money. But Leonard Syme, after so many years of studying categories, says, wait a minute, maybe we shouldn't even think about heart disease and diabetes because all of these diseases, or many of these diseases, have the same few ideologic factors. And maybe we ought to think about the ideologic factors and then think about how to deal with that. But that's asking people to think beyond where they are now. I do believe that what we need to do is to think hierarchically. You know, one of the things that we've been struggling with is how to do this hierarchical data analysis, because I'm trained as a biostatistician and this is what we do, unfortunately. But, you know, how do we look at different levels so that they're all interacting at the same time? And it may be mathematically complicated, but in terms of intervention, it's really not that complicated. So we look at obesity. Why would an educated black man living in a town like Chapel Hill with all kinds of exercise resources, married to a physician who constantly tells him not to eat junk food and to lose weight, and he still does it? That's me, of course, in case you didn't figure that out, you know? Because he's thinking about other things. He has these competing risks, and for him, his own health is less important than the ideas that he has about how do you change health disparities generally. Now, that is absolutely stupid, and what he should do is read the prescriptions that the Surgeon General gave him a few years ago about how to take it. You got another one for me. You know, I know that, but, you know, that's why I'm saying this whole thing about education. Do you really think I don't understand how to deal with heart disease? Do you really think I don't know about diabetes or cancer? Of course. But it doesn't mean anything in terms of what I do. And I think that we've got to understand more clearly why people do what they do.
And how to motivate people to
Absolutely.
healthy behaviors. That's a very important point.
Mm-hmm.
I'm glad you made it.
I want to ask a few more questions, or at least one more, and then we'll take a pause to see if anyone has any questions in the audience, because I do want to allow individuals to ask questions. But having had the privilege of being mentored for more than, is it 2 decades perhaps, by Bill Jenkins from both my church and through my graduate years and through my affiliations, both with Morehouse and outside of Morehouse and at CDC. Is there anything else left? I guess I got my wife on my own. So I should be grateful for that. But
it's amazing you're still standing.
Recently, I was visiting the U.S. Department of Health and Human Services Office of Minority Health website, and they appropriately acknowledge some of the black history makers in health, you know, because it's our time. And certainly, both of the panelists today are black history makers in health because of the major impacts that they have had, among other things, on black people in general, on health research of people of color, and on the institutions and programs that serve blacks. Although, and because you have achieved greatness, I do think it's important for us to remember that everyone starts somewhere, particularly for our young, aspiring future black history makers that are in attendance. So I want to ask you to share with us the name of a black researcher or a person who you felt personally made a real difference for you in either helping you to achieve or to better understand what you needed to be doing in your either personal or health career, and of course it doesn't have to be a researcher, but a person. If you would just take a few minutes to give us some insight on how it is that you have become the great men that you are.
Well, I don't know about me, but I love my ideas. You know, I don't know that I'm that important. But the first person I would think of is Al Haynes, who introduced us.
Well,
That's right.
I was a fellow with Al Haynes.
That's right.
Go ahead. You take
No,
that.
no, no. Yeah, but that was 1970 or 69, somewhere in there. And so he was, important to me because in spite of my tendency to be a little bit straightforward, I have mellowed, actually, since the first time we met.
Well, for those who don't know, tell us who Al Haynes was.
Oh, he was dean of Drew Medical School, and but you probably know of his background more than I do.
Yeah, he's one of the really outstanding public health researchers, I think, in our history. He was at Johns Hopkins when they decided to develop the Drew Medical School in conjunction with Martin Luther King Hospital in Watts. And I think he joined them in 1969. But he came there with this community attitude. So he chaired the Department of Community Medicine first and then later became dean. I went out to Drew in 1972 after having gone to Case Western and trained at Rochester. I decided that, that I wanted to get involved back in the community, and I heard about Al Haynes. And so I was fortunate to get a Macy Faculty Fellowship to go out to Watts to work with Al Haynes. And it was just an amazing experience. I don't have time to tell you what it was like to work with him. He's just an amazing human being in terms of caring, in terms of the ability to relate to the community, and yet sort of like Bill Jenkins, use the highest standards of science, and biostatistics. I mean, he could bridge that gap between that technical aspects of what we do and the community, develop really good relationships working with people in the community. And so, but I was going to, I'll mention one other person whom I never met but influenced my life greatly. When I was really young, I became very ill with whooping cough and pneumonia. A lot of people know this story, but in Alabama, we lived out on a farm, and black people died at home, as many of you know, black children especially. And black physicians didn't have access to the hospitals to admit patients. There was only one black physician in Anderson, that was Dr. Jackson. So somehow my dad talked him into coming out to the farm to see me when I was very ill. And the story is that he spent all day there working with me. I had a very high fever. And when he left, he told my parents that he didn't expect me to survive the week, but he told them what to do to give me the best chance of surviving. And I've survived. And my mother told me that story almost every day. So when I was 5 years old, the one thing I wanted to do was to meet Dr. Jackson. So they said, well, for your 6th birthday, we're going to take you to town to meet Dr. Jackson. I never met him. He died that year. He died of a stroke. He was 54 years old. And but by the time I was 6 years old, I was telling everybody, I'm going to be a doctor just like Dr. Jackson, whom I had never met. I had no idea what I was talking about. Nobody in my family had finished high school. I didn't know anything about college. But I was as certain of that as I have ever been of anything in my life. Mm-hmm. So Dr. Jackson, that black physician, trying to practice in a rural community without access to hospitals, is one of my heroes.
Mm. Fantastic. There's one thing I'd like to mention. A lot of people talk about the Heckler Report, but the Heckler Report is really the Haynes Report.
That's right.
It's Al Haynes is the one who designed the report and made that first analysis looking at comparing mortality and estimating the years of life, potential years of life lost.
What's the report? I'm sorry?
The Heckler Report, the 7-volume thing. I would like to mention 2 other people because when I was a student at Georgetown in biostatistics, we would go over to Howard University on Thursday afternoon around 2 o'clock when Dr. Hildreth Poindexter and Paul Connelly would have lunch. And students, a couple of students from Georgetown, a couple of students from GW would sit there and let them tell us stories. You know, story after story after story about the Negro health movement back in the 30s and about, you know, how they had wanted to do a public health program at HBCU and so on. That was very important to me in terms of giving me ideas about what I wanted to do. Because several of us, when we got into management at CDC, we were able to put $1 million together and give to Howard to start an MPH program, which unfortunately did not work because we didn't understand HBCUs very well. And then later on, I left CDC to start the first MPH program at Morehouse School of Medicine. And I think that it was those conversations about what they had tried to do in the 1930s and weren't successful at that gave me the goals about what I wanted to achieve. And you know, it is absolutely amazing. Another point I want to make is you didn't see Howard students there. You know, on this campus, you have African Americans who have had experience and training, and you know, you walk by them. Because you don't take advantage. When I went to school here, I could go to Sale Hall and listen to, Tweed was his nickname. You'll know him as Martin Luther King Jr. But you could listen to him talk about what was happening with the civil rights movement. You can listen to Hosea and Andy argue vehemently until 12 o'clock at night about which way that the movement should go. You know, you could listen to Muhammad Ali and Malcolm X and Baird Rustin and Howard Thurman, you know, and we would be there until 10 o'clock or 12 o'clock at night listening to these people talking about what we should be doing in this country. I don't see that happening today. You know, after 2 hours, you know, people, you know, and if they aren't already on their phones, they get ready to think about doing something else. The kind of discipline that was required under Benjamin Mays at this university was enormously important, enormously important. And I just think that, you know, somehow there was a time when Morehouse men were trained to be servant leaders, not corporate leaders, servant leaders. And the difference is that a corporate leader makes the corporation serves him and have people serve the corporation. A servant leader serves his corporation and has his corporation serve the people. Those are very different ideas of management and success in this country. You know, my classmate and fellow math major is Herman Cain. We took very different routes about, you know, whether we should go corporate leader or whether we should go servant leader. Very different route, you know. But you got to understand, Mr. Cain selling hamburgers and pizzas to low-income black people made a lot of money.
That's right.
And he's sold junk food to poor black people. He's selling junk politics to poor white people. And he's going to make even more money, you know? But that's the difference in the road that young people are going to take. They have to decide which way you're going to do that. So, you know, I think the potential for the schools in this community is hugely important. But you've got to go back and learn history. Morehouse College would not exist if Booker T. Washington hadn't provided funds for this school in the 1930s. Booker T. Washington decided whether Morehouse was going to exist or not. And yet all of this effort that he made, creating, you know, National Medical Association, National Nurses Association, you know, the Tuskegee Architects, the George Washington Carver and his laboratory of scientists, and the Tuskegee Airmen, all of this absolutely incredible work, amazing work with very little resources. I created a school system that's now the public school system. There were Roswell schools in almost every county in the South. The black people were going to school and white kids weren't. That's why we have public school systems in this country, because white people couldn't allow that to happen. So, you know, all of this stuff that we could learn from, it's all right there, but it goes unstudied.
No, I just want to, the same question, and I've graduated from Morehouse, I guess, what, 4 years before Bill did.
Right.
And so I was here doing the civil rights movement and going to jail and to prison. But leaving with an attitude, and I told the students here a few weeks ago that when I graduated from Morehouse, I graduated with an attitude, and my attitude was, it was not enough for me just to go and become a physician and be successful. My responsibility was to make medicine better, especially for people, you know, who come from backgrounds like my own. So my attitude, because of all of that experience, was I have a responsibility. I didn't know how I was going to do it, but I knew that I had a responsibility to do more than just go out and be successful in practicing medicine. But I must say, and I see J.K. Haynes here, the teachers here at Morehouse at that time, I mean, Roy Hunter, of course, probably had the greatest impact upon me. I worked in his laboratory. He got me interested in research. But teachers like Mac Bay and Roy Hunter and Map and Bernie were just really committed people. And I owe a lot to them, as I think a lot of us do.
The force of culture is enormous, and yet we understand so little about it. And so, the literature on access to healthcare is huge, but it doesn't link it to the other things variables that I think are important, not yet anyway.
Let me just, this is a little different, but when we were doing the studies on the social determinants of health, Michael Marmot from England chaired the commission, and he did a study that showed that if you take a white man, college graduate in England, and you compare him with a white man, college graduate in the United States, the person in England has a life expectancy that's 5 years better than in the United States. And you know, the question is why, but when you think about, we spend so much money on health care, but most of it is for treating diseases. And how many procedures can you do? And so one of the major weaknesses of our system, of course, not just in health care, but our system of health, is a lack of emphasis on prevention and health promotion. So that was his explanation for why that's true. But I thought it was one of the very interesting findings, because we always think, you know, as you said, about racial differences in terms of disparities in health. But there are some other differences that are interesting.
Good afternoon. I was wondering, with the REACH program funded by the CDC and NIH, how is it that we can make the projects more translational, you know, in terms of research and really bench to bedside and connecting people across lines? Because you were saying that the people in the community are not necessarily bio experts, but how do we make it to where, you know, we can get the geneticists on the project, the math modeling people on the project, and really create really integrative reports in a sense? Because I've looked at studies about prostate cancer, and there's the genetic risk allele factors, and then there's, oh, why don't you go get treated or seek medical attention or things like that? But how can we really spin it across the line to really get to touch more people?
That's a great question. I think we've got to figure out a way to create more partnerships, team efforts. We've got to get people who are experts in the community working together with people who are, quote, experts in the university. And that's part of what our program is, and I see Sarita Cathcart back there, but we have a program, in addition to our fellowship program, we have the Community Health Leadership Program. And basically, we invite community organizations, including churches, to recommend people from the community to come and spend 12 weeks with us, 1 day a week. And when the CDC heard about this, and no, I guess I did a keynote address at their REACH program, and the people in the REACH program said, how can we come and be a part of this program? We didn't have funds to bring people from out of state. So the CDC last year funded us to bring, 18 people from 9 states. But the idea is just what you're suggesting. How can we create these teams? How can we create partnerships that involves people with expertise in community, with people with expertise in whatever we do in academia? That's a great question. That's not an adequate answer, but that's what we're trying to do with that.
I have a thing, levels of community participation is somewhere in there. It's right here, right. So here's this hierarchy that I sort of put together based on my thinking about the Tuskegee study of untreated syphilis in the Negro male. And let me start by saying this. People would ask about sharing power and how difficult that is. And one of the statements that I used to make at the National Center for Health Statistics when I worked there was that statisticians would rather share their spouse than their data. So, you know, this thing about power relationships and sharing is very difficult. One of the real problems, we started out suggesting that you should do community participatory research when you work in communities. We had gotten those ideas from Scandinavia, a meeting we had in Washington, and I think it was 1992, a year after the 1991 meeting. And we started pushing this whole thing about health disparities, community participatory research. But what I have found, especially after working at, at CDC, is that very smart people could figure out a way how to twist any activity to their own advantage. The fact of the matter is, if a person gets a grant and goes into the community, that research is already final. So it's not participation. There's no participation. And a lot of community participatory research, there's no participation because what you decide to study, how you decided to study it, is already decided before you even get there. So again, we need to have people who could think about these kinds of things in a different kind of way. Some people would say, well, the Tuskegee study will not happen again. Yes, it will. It won't be 1932 again. It may not be syphilis again. But what happened at Tuskegee is definitely possible for today. What caused it? What caused it was to have a black institution who was very concerned about its image and wanted to participate with CDC in this very important study. We had CDC scientists who got so obsessed with syphilis, they called themselves syphologists. They were so obsessed with the bug until they forgot about the people.
Well, you mean public health scientists, because it wasn't CDC.
Well, you came in, it was still
right.
1947. Yeah, right.
But later on it was transferred to CDC. But
right.
CDC came into existence in 46.
Right.
I'm just protecting.
So it was a U.S. public health service. Right?
Okay.
Yeah, so like I said, in 1932 it wasn't CDC.
Yeah.
In 1952 it was CDC
That's
though. So, I think that those same things exist. You still have scientists who are so obsessed with HIV until they forget about the people who have HIV. Those same things exist. And so I think that what we need to think about is the power relationships, because you still have these ethical issues. And when you do community participatory research or clinical trials today, you still have an issue of beneficence. One of the 4 criteria of bioethics, one of them is beneficence. What is the benefit of this research to the people who are participating in the study? That's still a problem with the kind of work that we do today. Autonomy. What kind of autonomy exists when somebody says, I'm Dr. Jones from Harvard School of Medicine, and I'm here to help you? People get intimidated by that bull crap, and I think that, what we have to do is to spend more time understanding how community people not only see themselves as experts in their contribution to the research. That means you can't go in the community and say, we're here to do this. You've got to go into the community and say, we're here about a certain set of issues, health disparities, and we would like to know, what would you like studied? What are the problems that you would want? Now the question is, how do you get CDC to fund something like that? REACH tries to do that. REACH gets closer than just about anybody else. But community origination research, where the community decides, that hasn't been done since the Negro Health movement, when communities decided. For example, I'm Geechee. I grew up on the Sea Islands. and we had hookworm. And I could remember the old men in my community where the playground was would come in the spring and dig trenches so the water would run off to reduce the risk of hookworm in my community. You didn't have to be, you know, to have a doctor from Harvard to figure out to dig a trench, you know, but they solved a health problem because somebody came and said, we have a health problem of hookworm. What should our community do?
It's interesting, you know. I remember when I was Surgeon General, and we had Hurricane Floyd. I don't know if you remember that in North Carolina. So I was sent by President Clinton to make sure that, you know, that the health issues were taken care of. So I worked with the Commissioner of Health, and I remember they pulled together this meeting of students from North Carolina, A&T, Duke, the rest of them, and a student introduced me. So when the student got up, he said, the two biggest lies of history are, one, the check is in the mail, and two, I'm from the government and we're here to help.
And then you came on board.
But seriously, I think we're moving in the right direction in terms of this new focus on social determinants of health. We need much more money in that area, but I think certainly the National Institute for Minority Health and Health Disparities, we're trying to increase the funding, and we should all be concerned about that because there's a danger of their losing funding. But that's the institute at NIH that's funding this research in social determinants of health. And so we have to exert our influence in terms of making sure that that funding continues. And as I said, it's probably done more to build the research infrastructure of our institutions than any other program. And that includes building young people who want to do research in these areas.
Thank you. Next question.
Dr. Jenkins, you commented on the association between incarceration rates and HIV, which most people wouldn't make that connection that easily. So it made me think about the fact that for African-American males aged 15 to 24, homicide is currently the largest killer, and I believe it's also the largest killer for another age group as well. So how important is violence within the community, not in terms of life expectancy, in terms of just health burden in general? How important is violence in this disparity that we see between European Americans and African Americans?
I think it's hugely important. And it's not just physical violence. There's all kinds of abuse that we have to be careful about. You know, I'm going to say something personal that I don't normally. I grew up in a village in which there was a Quaker school. 5 generations of us were Quaker educated. I'm a Quaker, so we don't believe in violence of any kind. And so my daughter was in a grocery store, and she'd never seen an adult hit a child. Never. And we were at a grocery store, and this woman hit her child. And my daughter was just, you know, she couldn't understand it. She couldn't understand how an adult could hit a child. But we've got to talk about how we have to let people know that such behavior is inappropriate. And she wanted to spank me after I said something, as well as her child. But it is important to say something, because the fact of the matter is, you hit a child, that child sees that a way to get something is through physical violence. And so when he needs something and he's 18 or 19, he's going to say, well, my mom taught me that this is how I can get what I want. You know, I could either get it by a gun, or I could force some young woman to give me what I want. Violence is hugely important. But even more important is that if you take away violence as an option, it forces us to think about another way to work things out. That's really important. One of the most important factors in infant health is neglect and violence of children. If black men are taught to how to be supportive of women, particularly during the time that they're carrying a child or when the child is young. Hugely important in this period to be as gentle as possible. We need to somehow figure out programs to show black men that this macho thing is stupid. I want to mention one other thing. I was not a nonviolent person when I was young until on April 8th, a year after ML was assassinated in Memphis, a policeman stopped me and said, you know, boy. And I don't know. The next minute I found myself, you know, K Street is in downtown Washington. I am on K Street fighting with a policeman over his gun. The height of stupidity, if there ever was one. But what I realized in the middle of this insane situation was violence is not the answer. You know, violence is not the answer. I was extraordinarily lucky, as I have been most of my life, is that two very large black policemen came and slapped me upside the head, put me in a paddy wagon, and then later let me go for whatever reason. But since then, I've known that I have a responsibility because by every right, I should be in jail, should have been in jail for the next 20 years.
Or dead.
Or dead. Rather than going to Georgetown, Chapel Hill, and Harvard, I would have been in another kind of jail. So, violence is, sorry, I didn't mean to, okay.
Thank you
Go
very
ahead.
much. We appreciate that. Next question.
And I'm happy that this topic came up because my question was, I'm a young public health professional and my specialty is and will continue to be in men's health research. Why is it that research among African American men is so limited in general, even with HIV and AIDS and health disparities? Why is it so limited?
Well, one of our men health researchers is sitting right there on the Thursday. Well, you're coming out with a book soon, right?
Yes.
Claire? So men's health is one of the major areas that we work in. But Claire is one of the people. That's a very good question. I think in this country, that's just an area where we take a lot for granted in terms of black men, especially. And well, you know, in recent years especially, the gap has really widened in terms of black men graduating from high school. And most of our colleges, the ratio is like 3 or 4 to 1, women to men. In addition to what that means for men, you think about what it means for the women too. But that's what we're dealing with. So this whole issue of black men and their experience growing up, usually in single-parent households, and you know, these single parents have a really tough time. But within that whole structure, our young men are often not getting the role models that they need, drop out of school early. What is their 80% chance if they drop out of school that by the age of 30 they'll be in prison? Mm-hmm. So all of these things are connected. There's a connectedness, and there's a connection to the violence. And so if we did nothing else but really get to the root of this whole issue of parenting, you know, you can graduate from high school without taking any courses in parents, and yet more people are going to be parents than any other thing.
And
so
husbands.
Sooner or later, we're going to have to decide whether, in fact, we take parenting seriously enough in this country that we're going to do a better job of preparing people to be parents. And, of course, we all have that obligation as members of the community.
Thank you. Next question.
Kendall Sands, a freshman biology major here at Morehouse. And one thing you mentioned earlier with Herman Cain and how y'all went on separate paths, essentially the corporate path compared to the service path. And as a biology major, I'm currently trying to decide where I want to go, be it PhD, MD, whatnot. But even on the PhD side, you know, how, will I be in the more high-level, affluent hospital? Will I be working with whatever urban community? How would, and you talk about, you know, your criticism of Morehouse right now is how they lead people, at least obviously with a business major being the preferred major of the college, on the corporate path. Well, do you feel that not necessarily pertain to just Morehouse, but send people on other fields like health into the corporate big pharma path? And how do you feel like people, someone like me who's currently assigned, could try to figure out a way to do service while still paying off medical school?
Well, the very first thing is do what you love. Do what you love. I grew up in a family that said, you know, go to med school, you know, except, and my grandmother was the nurse midwife in this little village. She helped birth all the babies in this little fishing village I grew up in. And the first time I went out with her, it was interesting. The second time I went out with her, it was less interesting. About the third time, I was like, Jesus Christ, did you do something different? You know, medicine was not for me. I didn't like people that much, and I definitely didn't like doing the same thing over and over again. My brother, all he wanted to do, he was like you. At 7, he said, I wanted to be a doctor. I'm a doctor, you know, and that's what he did. But so the first thing is do what you love to do. When I found epidemiology, I couldn't believe it. I just could not believe it. That I could use my mathematical skills to solve biomedical problems. That was, you know, and that was from Dr. King, who was probably the most boring teacher I've ever had in my entire life, you know, and I fell in love with it. That's the most important thing. The route that you take, in this country, having an MD gives you an advantage. Having an MD and a PhD gives you a real advantage, you know. But the most important thing is doing what you love to do and try to be good at it.
Amen.
Thank you very much. Those are great words, very wise. Next question. We only have a few minutes left, so please be brief.
Okay. Hello. Thank you, Dr. Satcher and Dr. Jenkins. My name is Kelsey Kelly, and I'm from the University of Virginia. And my question is, what advice can you give us scholars so that we, as we become public health researchers, that we take not only an approach that incorporates the traditional method, but also innovative, so we can effectively promote and impact positive change, and not only on a local level, but at policy and other levels as also?
Well, I mean, I think the sooner you get engaged with community and you integrate that with your study, the better. And I think for me that has been the difference, the opportunity, working with Al Haynes especially, to integrate my work in medicine and my work in the laboratory with work in the community. And really getting involved with people in the community, getting to know people in the community, becoming trusted by people in the community, just gives you a different perspective when you go back to the hospital or to the laboratory. And so I would encourage you to maintain that connection that so many people lose. The reason I left Rochester, where they had said that, you know, if I stayed, I was going to be chief resident, I knew that I was losing that connection. So I went to Watts because I valued that connection, and I was just fortunate out there to have a mentor like Al Haynes.
My advice is question everybody, question everything, question yourself. So question, you know, and you will figure it out.
And be sure to question Bill Jenkins.
Yes.
Okay, our last question.
Hi again, Dr. Jenkins. Hello, Dr. Satcher.
Hello.
Both of you have worked in the federal government before, and kind of looking ahead to the future of health disparities research, I'm kind of seeing the writing on the wall in terms of funding, because there's an impending budgetary crisis and CDC's already been facing some cuts. How do we best prioritize the limited pool of resources that we're going to have for public health research?
Well, let me, while you're thinking that,
Yeah,
to the extent that we are able to prioritize, sometimes we don't have that opportunity. And obviously we've got to use our advocacy to try to get the right priorities funded. But a lot of times when that money comes out of Congress, you know, they've already done the prioritizing. But obviously we've lived through tough times before. And again, when you face tough times, one of the most important things is to have the right partnerships. And you can do so much. We say in our center that sometimes partnerships are more important than money. And it's true. We get things done through partnerships that we can't afford to pay for. But we've developed relationships in the community with agencies in the community. And so we get agencies willing to take our fellows, our scholars, for 2 months, 4 months. And not only do they not charge us, sometimes they even fund us. So there's no substitute for developing real partnerships in whatever area of work you're involved. Make sure you have those partnerships.
The two things. One is money. You got to think about things differently. Money is simply a piece of paper that translates foot-pounds of labor. There are all different kinds of ways of getting foot-pounds of labor to do what you want to do. It's not just money. The second thing, in America, it's like a balloon full with water. If you compress it in one area, it simply moves to another. So when the government lacks money, foundations tend to have more. It's always been this sort of fluidity in America. Think entrepreneurially. Think about where the money is. My reason for going to government is, you know, the bank robber Willie Sutton. When they asked Willie Sutton why did he rob banks, he said, because that's where the money is. You know, that's why I went to CDC. Because a poor little boy, Geechee kid from South Carolina wasn't going to be able to manage $10, $15 million a year unless he worked for the government, you know? And I think that once you get in the government, then, you know, I'm not as nice as Dr. Satcher. I will admit that. You know, I got money anyway by any means necessary. You know, if there's somebody, and I'll honestly tell you this, if there's somebody I needed to get money from, I had a friend who I needed to get some money from, and he just wouldn't give it to me. And so one day I followed him into the bathroom, and while he was standing there in a vulnerable situation, I pressured him about giving me this $50,000 for a project.
In a nonviolent way.
He gave it to me. You do what you have to do, but you have to have a reason for doing it. It can't just be for yourself. To me, it just can't be for yourself. But there are all kinds of ways of getting things done in this country. You know, that's what's so incredible about this country is that if you think about it, if you think about how to get things done, there are all different kinds of ways how to get things done.
Well, I want to thank you. That's an excellent question, really, to close this out, because at the end of the day, it is about thinking about the future and how do we work with what we have to be able to accomplish the goals we have that we need to achieve. I want to thank our esteemed panelists, Dr. Satcher and Dr. Jenkins, and I can say that both of them, I think it's important for us to recognize that these gentlemen take time out of their schedules to do things that is also a part of the community. You know, these are men whose time is greatly in demand, and albeit this is your alma mater, it takes time and you're in demand everywhere. And I can recall when I was a doctoral student at University of Michigan, both of you took time to come and speak, although I was, working, Bill, when you were,
right.
When you spoke, I was in a dissertation. Thanks for recognizing that I wasn't in attendance. But Dr. Satcher, I remember you took time to shake anyone and everyone's hand who wanted to speak to you. And the University of Michigan is not a small, even though it was a school of public health, place. So what I leave you with is the idea that while it is all the things we've talked about, it is also at a personal level. And when you become, I like the way you said, Bill, not necessarily a great man, but a man who thinks of great things, you are in more demand. And it's important, and you spoke about this at the APHA conference, about the difference between mentoring and role modeling. But both of those are important elements. So I hope everyone here takes a moment to understand this is mentoring, this is role modeling, and this is a contribution towards addressing health disparities that we all work to address. So please give me, join me in thanking our panelists and a round of applause for their time. We have a small token of appreciation for your gentlemen's time.
Okay.
Appreciate it.
Yeah. I'm looking to the next round of the David and Bill show.
So I assume we can be adjourned.